The stimulation is applied to a nerve. The easiest and least expensive way to assess the response is to observe or feel the response of the muscle. This method is easily adaptable to any superficial muscle. Single twitch. The simplest way to stimulate a nerve is to apply a single stimulus at intervals greater than 10 seconds. This interval is needed to allow the neuromuscular junction to recover if non-depolarizing agents are used. The single twitch modality is useful to construct dose response curves and to evaluate onset time. Tetanus. When stimulation is applied at a frequency greater than 30 Hz, the mechanical response of the muscle is a fusion of individual twitch responses. In the absence of neuromuscular blocking drugs, no fade is present, and the response is sustained. During non-depolarizing blockade, the mechanical response appears as a peak, followed by a fade. Train of 4. With the train of 4 supramaximal stimuli are given every half a second. Each stimulus in the sequence triggers a muscle contraction. The fade in the subsequent responses provides the basis for evaluation.
So that is why you're here today in this class, to learn about the neuromuscular blockers, right? Let me get this on full screen here. And so why are you using the neuromuscular blockers? We just have to start at 1. Anyone? Why are you using them? So they don't move. Well, can't you use your anesthetics for that? Too deep. No, not necessarily. So you're on to something, though. What are you on to? But you said they're too deep. You don't want them to move. They're too deep. You're touching on the fact that can you use lower concentrations of anesthetic to keep them from moving? Absolutely. So surgical immobility is a use. We spoke about the use of neuromuscular blockers briefly in the last block with succinylcholine and electroconvulsive therapy, right? You don't want them to move and hurt themselves after you stimulate, right, the brain and they convulse. And then many of you in the ICU have used the neuromuscular blockers to keep your sedated patients from moving, to facilitate ventilation. So many of you are familiar with these drugs. Now, with that being said, let's do a quick review of the physiology. And I'm going to record this as well. So what you see in front of you here is a nerve terminal. Can you see both of them? Yep. A nerve terminal and a motor end plate. You're familiar with that, correct? You also see in the green, these green receptors, those are your nicotinic receptors. And you have 2 types. The nicotinic muscle that you learned about, and the nicotinic neuronals. What's the basic difference between them? Where they're located. Nicotinic neuronals are on neurons, presynaptically, and the nicotinic muscle is on the motor end plate. Correct? Now, I do believe you also learned briefly about motor input potentials and how they occur and how they have to summate, and then you get your action potential and your muscle contraction. And so that should be familiar with you. What do you know that has to happen with the nicotinic muscle receptors? Acetylcholine. How many molecules? 2 molecules of acetylcholine have to bind to the sites on the acetylcholine receptor. That opens it up, and what happens? Sodium comes in, depolarizes the muscle cell, and potassium comes out. Eventually, you build up enough of a local potential to create an action potential that goes down to T tubules and The rest is history, right? Am I saying anything that you haven't learned yet? Got it. Okay. And the gist of this block, of the neuromuscular blockers, is the nicotinic muscle receptor. You're going to give a depolarizing neuromuscular blocker. And how do you think that's going to work? Because it's in its name. Is it going to mimic, or is it going to act opposite to acetylcholine? It's going to mimic it, and that is succinylcholine. And then you have your others that you are familiar with, right? Your cis-atracurium, your vecuronium, your rocuronium. And do they need to bind both receptor sites to cause an effect? No, just one. So in a nutshell, briefly, that is the physiology that you're dealing with when it comes to this pharmacology. You are blocking that postsynaptic target, those nicotinic muscle acetylcholine receptors. Tracking? Got it. Okay, so moving back here. Before we move on, are there any questions about the physiology at the neuromuscular junction? What are some of the important items that we more than likely are going to discuss? We already said the acetylcholine receptor. But we're also going to have to discuss acetylcholine. We're going to have to discuss vesicles. We're going to have to discuss how vesicles are released, calcium measurement. We're going to have to discuss how acetylcholine gets broken down. And the other systems that are involved to terminate the action of your neuromuscular blockers, correct? So those should be things that you're thinking about as we progress through these slides. Now, the first thing that you remember, it's been a while since you've been on the floor, is that you're going to give either your depolarizing neuromuscular blocker, like succinylcholine, or your non-depolarizing neuromuscular blocker, like rocuronium, in someone's IV, correct? For the most part, 99.9% of the time. And then you know that you have to get this into the circulation, into the plasma, and eventually to the target. Now, so you can get some perspective of what is going on, you have to realize that your arterioles and your arteries have to deliver this drug to your postsynaptic target. And that is going to juxtapose these arterioles. But what does that tell you about the drug? It has to do what? It has to diffuse. Are these capillaries that the arterioles turn into capillaries, are they continuous or do they have pores? They're fenestrated, right? They're not like the blood-brain barrier capillaries. And so, what's going to happen is the drug is going to move from the red here, right, the arteriole to capillary, and it has to find its way to the motor unit, to the neuromuscular junction. Now, here's a cartoon of an electron micrograph that shows 3 muscle fibers and how one nerve, Dr. Christie would tell you that one nerve can innervate many muscle cells, but only a muscle cell is innervated by one nerve, right? So that's what's showing here. And then you have your capillary that's delivering what, Lance? What will your capillary deliver to that motor output that you just gave? You just gave that drug, and now that drug is in the capillary, and it has to diffuse out to one of these muscle cells and find its way to the synaptic cleft, which lies beneath the neuron and between the muscle cell, the motor end plate. So that's where we're at here. You see the motor end plate and this black fuzzy stuff? What do you think that is? Densities of receptors. That's right. Densities of receptors. And what kind of receptors are these that we're focusing on today? Acetylcholine. Both the nicotinic neuronals, because they're important, and the nicotinic muscle cells. All right? And if you want to see an electron micrograph, this is what it looks like. You've got the yellow nerve terminal, you've got the blue and black fuzzy area with the receptors and the vesicles, and you've got the red postsynaptic target. That is very, 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 very tiny, but you can see there's hundreds and hundreds of vesicles and receptors. So just think of the magnitude of acetylcholine release when that axon terminal is stimulated. Right? If you remember, the nerve gets stimulated, electricity goes down the nerve, finds its way to the axon terminal. Right? The axon terminal has these voltage-gated calcium channels. They open up and allow what in? Calcium. That calcium combines with a couple of proteins, and what is immediately released? Acetylcholine. Did you learn about how many molecules of acetylcholine are in a vesicle? A whole bunch, like 5 grand or so. Right? So you're releasing sufficient quantity to have that motor end plate potential occur, and then you're going to have a muscle contraction. Okay? And we discussed how that happens. So what are we doing? We're giving drugs that will compete with the acetylcholine for the binding sites when we're discussing the polarizing neuromuscular blockers, or we're giving a non-competitive inhibitor, the succinylcholine, and it's non-competitive because if they both do the same thing, they're not competing with each other. Right? If they're both on the same team, they're not competing with each other. So which class of drugs are your competitive antagonists that we're going to talk about today? Your non-depolarizers. And which drug is a non-competitive antagonist? Succinylcholine, because they're on the same team with acetylcholine. So far, so good. Any questions right now? Okay, excellent. Now let's break down the neuromuscular junction to the presynaptic component, the synapse, and then the postsynaptic component. Presynaptically, we just discussed the importance of voltage-gated calcium channels in this process. So if we can interfere with the influx of calcium, then we can interfere with neuromuscular transmission. So some of the particle drugs that do this, that interfere with neuromuscular transmission, that you'll have to go over and over again, are magnesium, calcium channel blockers, and aminoglycoside antibiotics. Why? Because they inhibit the functionality of that presynaptic voltage-gated calcium channel. So, you see how vesicular release of acetylcholine is decreased. You have less calcium in the presynaptic terminal and a decreased release of acetylcholine vesicles. Now, just as an aside, temporarily, if you needed to, you could augment the patient's calcium levels by giving exogenous calcium and increase the muscle effect if you needed to. I wouldn't use that as a therapy, but just an aside. Now, clinically, this may come into play with certain patients, depending on their comorbidities, and certain patients that are on these drugs, it may not come into play. But you, as the anesthetist, have to know that when I give these substances, if I'm going to use muscle blockade, I have to account for this. And so if you're going to give muscle relaxants, non-depolarizers, for example, like the rocuronium, the cisaceturium, the vecuronium, would you adjust your dosage? I would hope you would. because at least in theory, you wouldn't need as much, right? Now, acetylcholine receptors are all along the synapse, in the junction. We're going to learn about junctional receptors. Later on, we'll speak about extrajunctional receptors. And so not only are they on the postsynaptic target, but where else are they at? Presynaptic. So postsynaptic is your nicotinic muscle. Presynaptically is your nicotinic neurons. Okay. Now they work the same way. Why would you have presynaptic acetylcholine receptors? Yes, sir. So he's saying that you're going to increase the acetylcholine release. It's a yes to the point, but I would also say this. Presynaptic acetylcholine receptors, what do they do when stimulated to the target? Do they hyperpolarize or depolarize? They depolarize. Okay, so the depolarization, is that a voltage? That is a voltage. What other channels did I just talk about that were voltage-gated channels? Calcium channels. Now, is acetylcholine released by the vesicles that are up high in the cleft, or the ones that are fused, ready to go along the membrane? So the ones that are fused, ready to go along the membrane, they're already gone with that first action potential. That initial voltage set them on their way. But it's the calcium, the continued calcium influx, some of it mediated by this presynaptic acetylcholine receptor, that allows the mobilization of the next round of vesicles to fuse to the membrane. So the next charge of electricity, what can you do? Release acetylcholine. And this goes on and on and on. Can everybody see that in your mind's eye? Now, if you can't, that's okay, because what I just said, I have on a video for you that explains how this occurs. And that's going to be labeled the theory behind, or what did I call it? Truth behind the train of four. Why you see four twitches with the train of four. And in that explanation is what I just said. Okay? And so when you do your train of four stimulation, if you have given no muscle relaxation, you get 4 equal twitches. And that's a reflection that each twitch, right, the first twitch releases, the vesicles fuse to the membrane, and then every other twitch after that is a reflection of what? How your presynaptic calcium influx is being regulated. And so if it's normal, you know that your presynaptic calcium influx is normal as well, which allows you to release normal amounts of acetylcholine. Yes?
You're saying that
is that absolute? It's hard to say that. The voltage change and this one with calcium both, I will facilitate that. But for your purposes, know that calcium will mobilize next round. That's kind of more important. Okay? So now we give. Everybody tracking with me so far? Because I don't want this block to turn in like last block. We're good, right? So, non-depolarizers, what are they going to do to acetylcholine? This is a non-depolarizer. It's going to bind to the acetylcholine receptor, and it competes with the acetylcholine. Now, this non-depolarizer, does it have an action when it binds? It has no action. There is no action. Nothing happens. Right? The receptor cannot open. There's no depolarization. There is no effect. Nothing happens. Do you need both sites of the acetylcholine receptor? Right? Because it has 2 active sites. Do you need both of them bound? Just one. Okay, so we're there. We got that. But it's not just the postsynaptic target that the non-depolarizers bind to. It's also the presynaptic nicotinic neuronal receptors, because they're nicotinic receptors. And what I just said about the nicotinic presynaptic receptors is that it helps to do what? Increase calcium flux between stimulations. So now, if I give a non-depolarizer and I block a presynaptic nicotinic neuronal receptor, do I increase or decrease the depolarization of the presynaptic nerve terminal? I decrease it. Will I increase or decrease the amount of calcium that enters the presynaptic nerve terminal? Decrease. Will I increase or decrease the number of vesicles that are released from the nerve terminal? Decrease. And will I see an increased or decreased muscle contraction response? Decrease. You have just explained fade. Okay? You have just explained why you get fade in your train of 4 monitor. Because what is responsible for the release? Well, I'll go with Ann. For what's partly responsible, along with the initial voltage, for the first release and then the subsequent mobilization of vesicles? Calcium into what? The presynaptic nerve terminal at the neuromuscular junction. I'm trying to be animated because I know you're all thinking about tomorrow. So I'm going to walk around, do everything I can to engage you. Now, a nicotinic acetylcholine receptor is ionic. It's an ionic receptor, meaning that when it's stimulated, ions flow in and out. It doesn't involve any type of metabolic machinery to relay its message. And ionic receptors, in general, have 5 subunits. You've learned about the benzodiazepine. It has 5 subunits, or the GABA receptor, it has 5 subunits. And then the acetylcholine receptor has 5 subunits. And typically, right, there is 2 subunits that are alpha, one that is beta, one that is gamma, or delta, and one that is epsilon. I'm sorry, delta and epsilon, because gamma is a bad one. So what have we learned? That this is a 5 subunit receptor that is located in the neuromuscular junction at both the postsynaptic target, the motor end plate, and the presynaptic neuron. Now, the presynaptic neuron is a nicotinic neuronal. It has 5 subunits. It's got a little bit of a different configuration than the muscle subunits, but they all have 5 subunits. Now, in general, you can say that the subunits are 2 alpha, a beta, a delta, and an epsilon. Okay? Yeah. Okay, no problem. Sorry about that. I had a faux pas with my PowerPoint.
It's recovered in your email.
Sweet!
I've already uploaded to the Blackboard the recovered file. If you go onto ours, you'll be able to pull the updated PowerPoints now. Go into ARM S3 and you see a PowerPoint uploaded, and that's the slides he's got up here now.
No problem. We can actually take a couple minutes to do that, because it's kind of hard. I don't know if we're going to make it today. 5-minute break.
What's going off the slides?
That's distracted? Yeah. I I think we'll take frequent breaks there.
It's watch this. It's 93 music.
Frequent breaks. Maybe we'll make another half an hour.
You uploaded it in the platform. It's under Farm Test 3.
Appreciate that.
If you get animation, I'm going to go against it lost. I got 34 centigrade, which
That's one thing I don't do with
Nothing
the
like the
animations. I'll have a video or something.
80% humidity and 104 to 109 degrees every single day. Suck it up.
that sounds awesome. I can't wait to do that. I'm looking forward to that.
Which one is it?
The circular release and a decreased muscle contraction. That's your favorite.
If you don't see it, press long hold down, and it'll refresh.
So all of you that were doing non-muscular monitoring in the ICU, what do you think?
What's
It's amazing that farm agrees to go power level for the presentation.
Yeah.
That would be muscular makeup.
It's warmer over here.
It is. Everybody got it? Still getting there? Okay.
So, wait till Jake's to come. Yeah, that's good. I just need a bunch of those suggestions.
So this is like
Okay, while we're waiting, I'll say this. You guys are going to learn about muscarinic receptors. They have nothing to do with muscle. Just because they begin with MUSC doesn't mean anything. These are not nicotinic muscarinic receptors. These are nicotinic muscle receptors. Muscarinic receptors are their own separate beast. And they're not even ionic. They're G proteins. When you get introduced to muscarinic receptors, you will get introduced to Mr. BB sludge. The parasympathetic response, meiosis, rhinorrhea, bradycardia, bronchoconstriction, salivation, lacrimation, urination, defecation, increased GI motility, and erection. That is Mr. BB sludge, and those are nicotinic, or those are muscarinic receptor mediators. That's it. Everything else, essentially, is 6 text. Yeah, that's your parasympathetic response.
No, I got it now, sir. Okay.
Are you ready? I'm giving you one more minute, then I'm going. Because I'm taping this, too. All right, we're going to get going again, because I am taping this. This will be on Blackboard later tonight. All right, so why are subunits important? Well, we're talking normally we're talking about junctional receptors. And when I say junctional receptors, that means they're in the junction. They're in the neuromuscular junction. But you're going to learn later on that if you get crushed, you get burned, and it's longer than 48 hours, you're going to develop extrajunctional receptors along the sides of this neuromuscular junction. You think that's a good thing? It's not. So if you have trauma or burns on a victim, you may not want to give succinylcholine. Because think about what these acetylcholine receptors do, because that's what they are. These nicotinic acetylcholine receptors are ionic. Sodium goes in, but what comes out? Potassium. So if you've got a bunch of extrajunctional receptors that upregulate because of burn or crush injury or a denervation injury, you get these things that are immature that start to develop, and they're outside of the junction. Hence, they're immature extrajunctional receptors. They also have 5 subunits, but what's different? The junctional receptor has an epsilon subunit. The extrajunctional receptor, instead of the epsilon subunit, now has a gamma subunit. Those are nice little board questions to see if you know the structures of normal versus abnormal nicotinic muscle receptors. Okay? No problem. I remember it like this. G, J-E-E-G, junctional epsilon, extrajunctional gamma. Because all the other subunits are the same. And so if I have a gamma subunit, am I a junctional receptor or an extrajunctional receptor? An extrajunctional, exactly. And what's the bad thing about having extrajunctional receptors? Well, they're only made if someone's immobile for a long period of time. Okay? Think about this. You're immobile for a long period of time. Your nerves into your muscles are not firing for whatever reason. Whether they're cut, whether you're just not moving, whether you've been on neuromuscular blockade for a week. And so, what are you not releasing into the junction? Acetylcholine. And so the motor end plate is like, dude, where's all my acetylcholine? I don't see any, so I'm going to make more receptors to try to get any response that I can. So you're upregulating these immature extrajunctional receptors. Tracking? Yes. We're going to go 2 days and 2 weeks. It takes about 2 days. Some books will say you're going to read some books that say 24 hours. You're going to read some books that say 48 hours. And you're going to read some books that say it takes 72 hours for these immature extrajunctional receptors to have any clinical significance. We're going to go with 48 hours up to 2 weeks, right? Or 2 years. 2 days to 2 years. And what's this 2 years? The 2 years is after 2 years of this continued process, it might be okay to use succinylcholine. But do you think Major Bentley is going to be using succinylcholine on someone who isn't moving very well? Probably not. Now let's say you have a crush injury. Here's where the 2 weeks comes in. So you have a crush injury, or a burn injury, or a denervation injury that magically heals in a couple of days. How long until those immature extrajunctional receptors go away? About 2 weeks, according to Stolzen. Right? Now, I don't really care if you know that, because if I'm your staff and somebody's had a recent injury, are you going to be using sucks? No. Right? Nope. But the one thing I will challenge you on is the conductance of these immature receptors. All right, so maybe the conductance of the sodium going in, maybe it's not as good, but you end up with more sodium in, potassium out. Why? Because the channel stays open up to 10 times as long.
So that is that. So why is this bad? That's why that's bad.
That's why it's bad. You have an exaggerated release of, you get hyperkalemic. Right? And what happens with hyperkalemia? So think about it. You've got here's a little trick that I've always used and it's always worked out. You've got two ions that you really need to be familiar with when it comes to action potentials. You've got calcium up here, and you've got potassium down here. Why are they up here and down here? Calcium is most responsible for your action potential threshold. Potassium is most responsible for your resting membrane potential that you learn with the Nernst equation. So, if I start taking a lot of ions, right, and I start pushing them out of the cell, what happens to my, do I hyperpolarize or depolarize the inside of my cell? Would I depolarize it? Where's my potassium going? It's going out. So what am I doing? I'm hyperpolarizing. And if I begin to hyperpolarize enough, can my automatic cells in my SA node do anything? No. Right? Now, if I inject potassium exogenously, then I force it in and depolarize. I'm with you on there. But you see how that can kind of help you where this ion is going? So that's why hyperkalemia, in this case, is bad. You're taking all of your intracellular potassium, and you are dumping it into your bloodstream. But the one thing Patrick is right about is that this is happening in skeletal muscle. Okay? This is happening in skeletal muscle. So those skeletal muscle areas become hyperpolarized. But Patrick is absolutely right now, is that that potassium has to go somewhere. And where does it go? To the heart. And now the heart is presented with an environment that is high in potassium. So what is it going to do? It's going to force itself inside of the cardiac cells, right? And when it forces itself inside of the cardiac cells, what happens to the irritability? The heart muscle, and I would say even the SA node in this case, because I got a little peppy, but the heart muscle begins to depolarize because of the release of the potassium at the skeletal muscles. Does that make sense? You're taking your potassium from your skeletal muscles, and you're throwing that all into your bloodstream. And now all of that's going to go to your heart. Your heart is presented with this high load of potassium, and now all of your cells in your heart take on more potassium. Is that a positive or a negative ion? A positive ion. So what does your heart do? It depolarizes. And what did I say that potassium was mainly responsible for in cells? Resting membrane potential. So what happens to the distance between your resting membrane potential and your action potential threshold? It decreases, and the cell becomes more irritable. And you start to see what? Arrhythmias, and then all of a sudden, you get so much potassium in there that your resting membrane potential actually exceeds your action potential, and you stay in a chronic depolarized state, and your heart can never reset. And that's when you go flatline. So, are we tracking? We've got this big response to potassium from the skeletal muscle. That area becomes hyperpolarized, but we take all of that potassium, throw it in the blood, and we depolarize the heart. So there is a pictorial of the differences in subunits. The mature has a epsilon subunit, the immature has a gamma. Please know the importance of that. Again, stressing the change in conductance time. Any questions so far on that? So, burns, crush, anything that denervates a neuromuscular junction is bad. You can lose your license if you give sucks in those instances, no doubt. Why? Because you take potassium from the skeletal muscle in that case, you transfer it to the heart, and the heart goes into standstill. That's not good. All right. This is going to seem foreign to you because you never associate neuromuscular blockers in the ICU with being a safe drug. But it has this high margin of safety. It has a very high margin of safety because there's so much redundancy built into the neuromuscular junction. So much redundancy. It is so redundant that you only need about 10% of your receptors available at the neuromuscular junction to have normal muscle function. Okay? That means you can give a half ton of non-polarizing neuromuscular blockers and still get a response. Look at that. And you will start to see a loss of function slightly when you have 75% of your acetylcholine receptors blocked by a non-depolarizer. Now remember when we first started, we looked at that twitch monitor, and we looked at the train of 4. And many of you are familiar with that train of 4. Many of you are. You may start to see the loss in amplitude of the first twitch when you have 75% of your junctional nicotinic muscle receptors blocked. You may start to see it, okay? And now, if you lose your twitch totally, you have, best guess, blocked 95% of your junctional receptors. Major Bentley, how do you read this graph? Excellent question, sir. All right, so at the bottom, you get this line that says, what percent of my receptors are blocked? And it actually correlates to the twitches that are programmed in the above graph. So, the dotted line represents a 75% blockade of receptors. And if you are able to draw a straight line up to where it says onset, that is where that first twitch starts to fade away. And then, shortly thereafter, you reach 95% saturation of your postjunctional nicotinic muscle receptors. And now, you can't release enough acetylcholine to overcome the postsynaptic blockade. Everybody tracking with this? And then over time, what happens? Your neuromuscular blocker starts to come off of the acetylcholine receptor, and then acetylcholine is allowed to bind, and then you start to regain your muscle function. That is that graph in a nutshell. So, when do you start to lose twitch height? 75% blockade. When will you lose twitch height? 95% blockade of your receptors. But why do we say that neuromuscular blockers have a relatively high margin of safety? Because you only need 10% to make the diaphragm go. Okay? So we're talking about percent response. We're not talking about actual numbers. If something happens to the absolute number, of the receptors in the synaptic junction, you still have to have a certain percentage blocked. So is there up or down region? Let's take that example I gave you about the increase in extrajunctional receptors, because they're still going to bind acetylcholine, they're still going to bind your succinylcholine, and it would be bad to give to those patients that are burned, crushed, or had a denervation injury. But what if we gave a non-depolarizer? Are those patients more sensitive or more resistant to that drug? So, here's the situation. You weren't hurt, and you had 100 receptors. Then you got hurt, and now you've got 10,000 receptors. And you still need to bind 90% of those receptors. Who needs more drug? The guy with 10,000 receptors. You need 9,000 molecules, or 18,000 molecules, because it's 2 sites, right? Versus that gentleman who only needed 180 molecules. So that's what is meant by percent occupancy. Jeffrey, how do neuromuscular blockers work? Good. So they block the nicotinic muscle receptor. Competitively or non-competitively? Well, it depends, sir. Are you talking about your depolarizing blockers or your non-depolarizing blockers? Non-depolarizing blockers are non-competitive, or I'm sorry, are competitive antagonists. Depolarizing blockers, the only one we use being succinylcholine, is a non-competitive antagonist, because you can't be on the same team and compete against each other. So we talked about how they bind to the alpha subunit, and you only need one. If I've discussed it, I'm going to move along a little bit here. We're given an example of the receptors here at the bottom, and curare is an old non-depolarizing neuromuscular blocker. So for your example, you could put rocuronium in there, you could put atracurium in there, you could put vecuronium in there. They're all the same class of drug. They all compete for that site. Now the reason that succinylcholine is non-competitive is because it is also known as diacetylcholine. What does that tell you about the molecule? There's 2 succinylcholine molecules that are bound together by an ester bond. And what cracks ester bonds? Esterases. And what do you have a lot of in the neuromuscular junction? Acetylcholine esterase. Sitting right next, excuse me, sitting right next to that nicotinic receptor. So what will happen is the acetylcholine molecule will bind for a short period of time, get bumped off, and get chewed up. It'll bind, get bumped off, get chewed up. I mean, very quickly. But the succinylcholine, right? There's 2 types of esterases, at least in this particular example. If you remember that first picture I showed you, I had the little green fluffy esterases next to the receptor on the postsynaptic target, but I also had some that were floating around. So the true esterases, the ones that are sitting along the membrane, they don't chew up succinylcholine. So what is the mechanism of action for the termination of the effects of succinylcholine? Yes, and the metabolic machinery of pseudocholinesterase, otherwise known as plasmacholinesterase. So what do? You inject a large quantity of succinylcholine. You flood the cleft with succinylcholine. Succinylcholine binds to the postsynaptic target and the presynaptic target until there has been enough succinylcholine chewed up in the plasma to create a diffusion gradient. And once that gradient is created, what happens to that succinylcholine that's in the cleft? It moves out into the plasma, and what does it get chewed up by there? The acetylcholinesterase, creating more of a gradient, which is why your your duration of action of steps is so slow. How much esterase do you have in your body? An enormous quantity. Right? Succinylcholine lasts, if you give ED95, 3 to 5 minutes, and if you give 3 to 4 times ED95, 10 minutes tops.
What was the first step in that? So how is the succinylcholine going to become detached then? So it's
Just Brownian motion.
so it's
Random
time
it's
aspect.
moving.
It's
Yep. It'll detach if it's got a gradient to move to, or lack of a. It'll go from a high concentration to a low concentration.
raw mass action, all that.
That's
applies
it.
Here, and it's,
Law of mass action says that eventually, after the acetylcholinesterase chews up the succinylcholine in the blood, that the stuff in the club will diffuse out. Anybody here ever seen someone with sucks and then they had the train of 4 monitor that was turned on? It's different than the non-depolarizers, right? We talk about this thing called fade with the non-depolarizer, and we know that fade means that the non-depolarizer is causing a condition in which there's less presynaptic release of calcium, or a presynaptic release of vesicles and less calcium, and so our muscle contraction gets weaker. That's called fade. It fades away. But succinylcholine's block is different. If you were to do a train of 4 on the monitor to look at the succinylcholine block, now it may be diminished, but all twitches are going to be equal. That is a phase 1 block. And we'll get more in depth with this. But that is a function of the fact that the succinylcholine only work postsynaptically. No, it also will bind to the presynaptic nicotinic neural receptors, neuronal receptors. And we know that succinylcholine causes a state of continued depolarization. Now, those of you that are starting to think ahead of me a little bit, think about what happens when you give succinylcholine to a patient. You ever see them fasciculate? Aha! Why do they fasciculate? Well, that's a presynaptic phenomenon as well. We learned that non-depolarizers and fade is a presynaptic phenomenon, but depolarizers and fasciculations is also a presynaptic phenomenon. So think about what this succinylcholine is doing when it binds presynaptically. We know what it does postsynaptically. But presynaptically, can you now see a continued state of depolarization in that nerve terminal? And now, a continued influx of calcium into that nerve terminal? And now, a huge quantity of acetylcholine being released into the flesh. It's not because of the succinylcholine that you fasciculate. It's because of the acetylcholine, the vast quantity that you just released into the cell. Because in order for a muscle to fasciculate, right, it has to set and reset, set and reset, set and reset. But succinylcholine doesn't do that. Succinylcholine binds to the postsynaptic target and continuously causes depolarization, so there's no reset. So it has to be the effects of a large quantity of acetylcholine being released presynaptically to cause the fasciculation. And there's good evidence to show that with increased dosing of succinylcholine, you see less and less fasciculation. Does anyone know why that might be? There's 2 things. So a good question to ask yourself. You probably see this again. When you give low dose of a drug, have you ever heard that most of the time it'll act presynaptically? That's a good rule to follow. A lower dose of a drug has a tendency to act on presynaptic sites, whether it's at the neuromuscular junction or at nerve-to-nerve contacts. Don't know why, just seems to be that way. So imagine that you give a dose of succinylcholine, and it's an ED95, and you start to activate the presynaptic nerve terminal. And all of a sudden, your acetylcholine starts to move into the cleft. Now you have binding, unbinding, binding, unbinding, binding, unbinding, and what do you have? Fasciculation. Okay, so let's give a whopping dose of succinylcholine. And that succinylcholine arrives both presynaptically and postsynaptically at the same time. Is there anywhere for the acetylcholine to bind if there's a bunch of succinylcholine? And hence you have no fasciculation. If you don't believe me, try it. Read about it. It works. A higher dose, 2 to 3 or 3 to 4 times the ED95 of sucks, takes away fasciculation. However, what do we know that succinylcholine will do? I told you about some bad things with sucks. You've got to look out for our plasma potassium concentrations. An intubating dose will raise the potassium equivalent, milliequivalents, 0.5 to 1 milliequivalent per liter.
So clinically, what does that mean? You got a on each case.
Make sure it's acute versus chronic, and then make a decision. You say, what do you got to do? If you got a patient that's floating around 5, what do you do? Is it acute or is it chronic? Does the patient live there or not? Can you give a lower dose of sucks? Is the patient mobile? You know what I mean? These are questions that you'll ask yourself as the circumstance dictates.
So when you're doing a rapid intubation in the ICU, and they ask you to come in and say, what's the potassium level?
Sometimes you don't know.
Right, but you got a current value that's 3.5. That's fine. That's better than 5.5.
What do you? Where's one of the? What's the potassium level, and do you have calcium available? Do you have calcium available, just in case?
So the why to that is what you just said. Exactly. High dose succinylcholine is going to cause that potassium exodus, essentially, to into the heart. You're going to raise the potassium level in the blood.
Yep. Succinylcholine will raise the potassium level in the blood 0.5 to 1 milliequivalent per liter. You got it. And all of that other stuff goes along with it, right? What's my patient's K? Are they immobile? What is the purpose of this intubation? Is it truly emergent? Because if it's truly emergent and the patient is not responsive, all you need is melanometry. That's it. Do we have any questions what fade is versus phase 1 block here? You see how fade goes away? So if I have 4 twitches, my 4th twitch will be less than my first twitch in magnitude. That's fade. If I have no fade, my twitches have all equal magnitude. Now, phase 2 block, that's going to mimic a non-depolarizing block. It's not the same as a non-depolarizing block, but it mimics a non-depolarizing block. And a phase 2 blockade can only happen with succinylcholine. That's it. That's it. Now, why does it look like a non-depolarizing block? Well, there's a couple of theories on that. One thing's for sure. You gave too much succinylcholine. Either you bolus too high, or there is some type of problem where the patient can't metabolize it, or you ran a continuous drip like they did in the old days, but there's too much succinylcholine around. So this is going to look like a non-depolarizing block in the fact that the 4th twitch magnitude will be less than the 1st twitch magnitude on the craniophore monitor. Now, why is this happening? Well, there is this general theory that it is binding to the postsynaptic receptors and creating this state of electrical imbalance. It's always a great thing to say when they don't know. But what I think it is, I think it's related to the metabolite of succinylcholine. The metabolite of succinylcholine is succinyl monocholine. And the funny thing about this is that it's got literature on it that shows it is a non-depolarizing neuromuscular blocker. If something's a partial agonist, what is it also a partial? Antagonist, that's right. So in 1954, I had to do some looking, but it was there. There is actually a dose of succinylcholine that you can give to a human and create muscle blockade for up to, what does it say, 12 minutes? So now can you see why phase II block, in my theory, mimics a non-depolarizing block? That's right. And the fade, if it's succinylcholine, I mean, this has been shown to be a non-depolarizing neuromuscular blocker. Everybody tracking there? No?
No. Sorry, I missed
Okay.
you said, but I kind of missed the point. I think.
So you'll see in phase II, you'll see
Phase II block, you see
yeah,
fade.
which are probably the same and diminishing.
So why do you see fade with that phase II block? Well, if it is in fact from succinylcholine, it makes sense because according to the material safety data sheet, what is it? It's a non-depolarizing neuromuscular blocker. So now you've learned why Dr. Bentley thinks phase II blockade is a non-depolarizing blockade. But never, ever, ever say it's the same as a non-depolarizing, because your staff in phase II will be like, oh yeah? Well, prove it. Write it up. Okay, whatever, dude. Direct channel blockade. Does a neuromuscular blocker need to bind to the acetylcholine receptor sites of the block? The answer is no. In fact, that's not even its primary action. If it could, it would want to get inside of the receptor channel and block it. Okay, think about that. It wants to get inside of the channel and block it. But that's usually not what it does, even though that's its primary action. Why do you think it has a hard time getting inside the receptor? Because it has to be activated. Right? And so instead of trying to work its way inside, the next best thing is to bind to one of the two acetylcholine sites and get the same effect. That's the point with this slide. Yes, it can get into the channels and cause a blockade, but clinically, this is not why you're seeing your neuromuscular block work. You're seeing it work because it's binding to the acetylcholine receptor sites on the alpha subunits. Right? So the site of action is the two alpha subunits in the nicotinic muscle receptor. Is acetylcholine broken down by true cholinesterase? Yes, it is. There's two types of esterases that we're concerned about with this block. True, the ones that are on the membrane in the junction, and pseudo or plasma, the stuff that's floating around. Acetylcholine is broken down by both. Succinylcholine is broken down by plasma, pseudo, whatever you want to call it. But you can understand with such a huge capacity why the effects of acetylcholine are so short. You release it, it binds for a millisecond, and then it's released and it's gone. So you don't continuously contract. You have a way to regulate your muscle contractions. The point here again is the alpha subunit is what we're talking about in regards to acetylcholine binding or succinylcholine binding or non-depolarizing neuromuscular blockade binding. Who thinks that they could point out where the cholinesterase breaks down the succinylcholine on this picture. I remember this question too, by the way. If I wanted to, I am an esterase, and I'm going to break down succinylcholine, but I'm not. The true cholinesterase is not going to do it. The pseudo will. Where am I going to break it down on here? Wham! Right in the middle is that ester bond. Two acetylcholines bound by an ester bond. And then when you break it off, you get succinylcholine and succinate. So I think I nailed that one to death. This is talking about the diffusion and the metabolism of succinylcholine. What slide am I on? It's going to be hot tomorrow too, isn't it? Take a 5-minute break. Take a 10-minute break. We'll try to get to slide 80.
Real quick, the PowerPoints I uploaded only went up to slide 50. The corrected PDFs are on there now with all 160.
Oh, but really, it's only like 20 pages of text.
The emails I sent you, the pre-programs into it, right? I've gotten this one at home for it, so you can actually edit it.
Okay.
So it's not just like images pretending to be a PowerPoint.
Does it break that cleanly? No, but you end up getting, that's where it breaks and you get substance.
So they're not actually go down the second half of that.
Yeah.
Or it's just one.
It's just one PDF on there. Neuromuscular drugs. They didn't PowerPoint because it's not right.
Yeah, my bad. I couldn't find it. I don't know what happened to it last year. And the one that I uploaded, the formatting was all sorted.
Really.
Is that phase 1, phase 2?
That's right. Phase 1 blockade, succinylcholine oil. Phase 2 blockade, succinylcholine oil. It's not getting too much of it. Way too much. So phase 1 block is, so here's my first round. No succinylcholine, it looks like this. 1, 2, 3, 4. With succinylcholine, if I get a response, they're all equal. 2, 3, 4. Fade now is 1, 2, 3, 4. It's phase 2 for suc. So it's normal. Monocholine is another form.
That's what that looks like.
No, this one actually is going to cross. Yes. Let's look at this one here. You're going to get a value estimate. Someone had the rates, and you're going to get the monocholine and the succinylcholine.
So, such should have a phase?
Should not.
Should not have a phase.
They're at phase 1. They're always going to be equal. It'll be depressed, but they're always going to be equal.
Okay, that's non-equal, right?
If I were to ask you what the phase 4 is, it's always going to be 1 exercise. So it goes away.
Right.
Because the fourth is always equal to the first. The fourth is always less than the first. Yep. No matter what height they are. But fade means that the first one's real tall and the last one is real small.
More ratio should be
Let's take a break. We can have a
Okay, I'll slow down. Hey. That's perfect.
The clock's not too bad, is it?
Oh my God, yes.
Yeah.
Just kids just get in the room. No matter what you say up there, nobody
Don't listen, sir. It's too high.
No, it's not that. It's good it's recorded.
Yeah, I definitely. All of my lectures will be recorded.
Yeah. So let's do it the second time. Or makes way more sense.
Does it work? I mean, does it really help?
Because then I listen to mine. I've listened to the integrity a couple times. Either way, if I'm in the car.
Yeah, as long as you're catching it.
Yeah, so I listen to the car when I'm driving. I got a little bit of commute. So, yeah.
Definitely helps. Where do you live?
I live up in Silver.
So do I. I'm in Shirts. You know where Lowe's is? Going right up 35.
Yeah.
There's a Lowe's on the right hand side.
I guess it's 175-ish.
Yeah.
Yeah.
So I live right behind Lowe's.
Okay. An HEB and what fuck places with that damn construction.
Yes,
We
sir.
use the counselor all the time. You gotta get 1 or 2 things doing that price.
The Walmart's actually nice too.
You know, Walmart is that's actually less hectic. You go to that Walmart, it's less crazy than that HEB. That place is huge.
And all day, every day.
I know. It's amazing. That the concept is only quite a grocery store.
Since I know none of you all are listening, I'm just going to keep driving on and recording. You all listen to it later.
Oh, no, I need to hear it twice. It's good. It's the multiple. It's the
Yes.
repetition. It doesn't work if I just record and listen. Yeah, that's scary.
I was supposed to go with you guys, but I haven't. I'll be happy if I get it inside. Tomorrow we'll pick it up a little bit. That's all right. Okay, gonna move on. Gonna try to blast out this last 40 minutes. Stay with me. Here we go. All right, what do we know that these drugs do? They block acetylcholine receptors, right? Now, are acetylcholine receptors only at the neuromuscular junction? No. Nicotinic neuronals are in the ganglia as well. They're responsible for your autonomic nervous system, right? Presynaptic, postsynaptic, preganglionic, postganglionic, all that stuff. So, if I am a non-depolarizing neuromuscular blocker, I can block nicotinic receptors. And if I'm old enough, I probably can hit some muscarinic receptors as well. Yeah? Remember that old drugs are dirty, they have crossover. So one of those non-depolarizers that is relatively old that we use is called pancuronium, and you know it as pagulon, a long-acting, non-depolarizing neuromuscular block. And because it's older, and it somewhat looks like acetylcholine, there is a tendency for pancuronium to cause this vagolytic effect to cut the vagus. And in that respect, you might see heart rate go up when you give pancuronium. So I would remember that. Why? Because it has a vagolytic effect. It cuts off the parasympathetic nervous system. It blocks M2, muscarinic 2, cardiac receptors. Now, it's the second generation, the third generation, the VEC and the rocuronium, they do not appear to do that. So if I am asking you about what non-depolarizer can increase heart rate directly, not really directly, but because of a receptor effect at the muscarinic 2 receptor at the heart, what are you saying? Pagulon. Okay? Pagulon. Because you get this vagolytic effect. Much, much, much weaker, if at all, compared to vecuronium and rocuronium. Now here's a nice slide to kind of show you. I'm not going to have you memorize it, but just look at the structures and see how they change. Up top, the black outline shows you vecuronium. The little blue add-on shows you what pancuronium looks like superimposed on vecuronium. Does everybody understand that the whole structure is pancuronium? And then if I cut off that little blue methyl group, I'm vecuronium. At the bottom, I have that base nucleus, and then in the red, there's vecuronium. And then if I just make a couple of changes at certain areas, I turn it into rocuronium. Now what's the point? They're all related. They're all steroidal compounds. They're all this steroidal compound. Aminosteroid. If it ends in an onium, O-N-I-U-M, it's a steroidal complex. And then as we move forward, if it ends in urium, right, it's a benzoisoquinoline. What? Okay, we'll get there. Now, you have the oniums, the pancuroniums, the vecuroniums, the rocuroniums, and now we have the uriums, the mivacurium, which they don't make anymore, but they should, atracurium, cisatracurium, and in the old days, the mivacurium and the atracurium, if you gave enough of it, you could actually see histamine release. So check this out. I just talked about the steroidal compounds, and one of them will increase heart rate because of a vagolytic response by binding muscarinic 2 receptor. Now I'm going to talk about the benzoisoquinones, which can raise heart rate, but it does it a different way. If I release histamine, I vasodilate, and if I vasodilate, what does my baroreceptor do to my heart rate? Increases it. Because when pressure drops, heart rate goes up. When blood pressure increases, heart rate goes down, right? So there may be some histamine response with mivacurium and cisatracurium if you ever use it. Or, I'm sorry, atracurium if you ever use it. Now, atracurium is this formulation of about 10 isomers. And they figured out, these chemists did, that one of those isomers, cisatracurium, you also know it as Nimbex, it's a very clean molecule with literally no histamine release. Much better than its parent, atracurium. Much cleaner. So this is a money chart, and it's not that hard. there's only 1, 2, 3, 4, 5, 6 things that change. We look at histamine release. Succinylcholine, yes, it'll cause histamine release. I haven't seen it much, but it definitely can do it. Atracurium, yes. Mivacurium, excuse me, yes. Now the second column says cardiac muscarinic receptors. Wait a minute, what kind of receptors are muscarinic receptors? Nope, nope. Are muscarinic receptors ionic or G protein? They are G protein. And on the heart, they're M2. And what do you know about M2? GI. Oh, you haven't learned it yet? Oh, sorry. Well, write this down. Kiss, kick. You know that, right? Kiss, kick, whatever. QISS, QIQ. Alpha 1, alpha 2, beta 1, beta 2, M1, M2, M3. What? I want you all to take a piece of paper and write G protein receptor on one column and G protein subunit on one column and receptor on the other column. And then I want you to go down on the G protein column and put QISS, QIQ. In other words, GQ, GI, GS, GS, GQ, GI, GS, QIQ, kiss, kick, QISS, QIQ. Now on the right, on the same line, right, one at a time, alpha 1 receptor, alpha 2 receptor, beta 1 receptor, beta 2 receptor, muscarinic 1 receptor, muscarinic 2 receptor, muscarinic 3 receptor. What did I just show you? What the alpha and beta and muscarinic receptors are. What G proteins they are. So now that we've... That's all right. On the left-hand one, GQ, GI, GS, GS, GQ, GI, GQ. On the right, alpha 1, alpha 2, beta 1, beta 2, M1, M2, M3. Now, in the heart, when it comes to the muscarinic receptors, a lot of emphasis is put on the M2. Now, according to that chart I just talked out with you, what kind of a G protein is it? And what do you know about GI proteins? They're inhibitory. So what do you expect heart rate to do when that protein is stimulated? Slow down, that's right. Succinylcholine, does it mimic acetylcholine? So you give a bolus of it, don't be surprised when the heart rate drops down. That's what that modest stimulation, right? That's what that's getting at. If I stimulate a cardiac muscarinic receptor, I may see bradycardia. Which is why you're told to always mix your atropine with succinylcholine in kids, because they have a high vagal tone. If you give succinylcholine plain to kids, you may see a severe bradycardia. So that's why. Because you're stimulating muscarinic 2 receptors, which are GI receptors. Yeah. Now, pancuronium. I told you it increased heart rate. Now you know why. If you block a GI receptor, if you inhibit an inhibitory receptor, what have you done? You've stimulated the response. Okay, so now, the autonomic ganglia. The only one that does anything at the autonomic ganglia is succinylcholine. That's a mixed bag, because what's at the autonomic ganglia? Both sympathetic and parasympathetic activity. That one you don't see as much. What do you usually see? The bradycardia in kids with the succinylcholine, or the histamine release and a little bit of redness. Now, any questions on that? That chart, just understand certain questions that I could ask based on this. And if it says none, it's probably not a good thing to ask the question on. If I told you that the ganglia was a mixed bag, I'm probably going to focus on histamine release and cardiac activity. Y'all remember potency for tomorrow? You know, what's left least potent, what's most potent? What is that really related to? The dose you give, right? Desflurane's dose is 6%. Iso's is 1.15%. Which one's more potent? Iso. So, okay, so same concept goes with these neuromuscular blockers. If you take vecuronium and you look at its usual formulation, usually it's mixed at 1 milligram per ml. And then you look at rocuronium or Zemuron, and how does it usually come? 10 milligrams per ml. So each vial is telling me that I'm giving roughly 10 times the dose with rocuronium. Maybe a little less, but because it's formulated so concentrated, I know that rocuronium is not as potent as vecuronium, meaning that I have to give higher concentrations. But what do we learn about with higher concentrations and onset? It's a quicker onset, and this drug doesn't like to bind as well as vecuronium, and it has a quicker offset. So rocuronium ideally has a quick onset and a relatively faster offset. Yes, ma'am. She's trying to hang in there. In kids, one thing you might see on the parasympathetic side regarding succinylcholine, if we're talking central effects, is that not only are you giving the atropine to help avoid the bradycardia, but also the secretions in the pediatric airway. Because if they're highly vagal animals, right, do they spit and slobber everywhere? Absolutely. So that's another reason to use an antimuscarinic in your succinylcholine. We already talked about this. And we talked about this. This is the bradycardia with the kids and sucks, and the pancuronium and the increase in heart rate. Now this is a stupid slide in my opinion. Stupid slide. Okay, why do I care about the acute hypoxic ventilatory response if I'm giving a paralytic? Okay, great, nice slide, move on. Okay.
Is that self-lead?
That's a stupid slide, don't you think? Why did I make it? I don't know, because what it says in the book. So I just don't understand the clinical relevance of this. A lot of it isn't clinically relevant, but just bear with me, guys, right? All right, so you see how this M2 receptor keeps rearing its head? Muscarinic 2 receptors seem to interact with the non-depolarizers. Muscarinic 2 receptors in the heart or in the lungs are inhibitory receptors. So, if my drugs will bind to this receptor, I better know what this receptor does. Now, back in the day, before you guys came along, after I came along, I never used Rapulon. Have you ever heard of it? Rapicuronium. So this was a very, very short-acting, non-depolarizing neuromuscular blocker. And for a couple years, it had great press. But then, there were several case reports of young adults and children dying from it. And it was actually causing a bronchoconstriction. So it would block GI receptors, okay? And then it would activate these M3 receptors. Now think about M3 receptors. What kind of a G protein are they? GQ. what does GQ on smooth muscle do? It constricts it. So this one, nonetheless, it got pulled off of the market. We talked about histamine release. The only ones that you need to be worried about were in that chart. But do you understand what histamine release results in? The big cardiovascular response we're concerned with is hypotension and reflex tachycardia. You use the word reflex with that. You always understand that it's baroreceptor mediated. Now, if I give you two classes of drugs, and I say pick the one most prone to release histamine when injected for the neuromuscular blockers, which class, the benzoisoquinolones or the aminosteroids, are you going to pick? If I say which class of drugs, because there's two broad categories we went over, the aminosteroids, the oniums, and the benzoisoquinolones, the ureans. Which ones release histamine the best? The ureans. Right? In fact, look at this slide is saying right there. You know where these drugs came from? You ever heard of curare? Monkey poison, right? Sir Walter Raleigh back in the day went down to the Andes jungle, I believe, and they were shooting monkeys out of trees with these darts. So this is what they were using. The second bullet here is incorrect according to the way I read it, but I did post it word for word from Stolten. Anaphylactic reactions. When I give you a non-depolarized neuromuscular blocker, or even central colon for that, it's very rare that you actually are allergic to these drugs. However, should it happen, it appears that it happens more in females than it does in males. Stolten has got this ratio wrong, if that's the way it's actually reading. I would flip it. But if you know the concept that males seem to be, or females seem to be more prone to these anaphylactic reactions, I'm happy with that. How do we monitor our muscle relaxation? Strand 4. Who here has done it? Okay. And like most of you, I never did it before I got here. There's some terms that Stolten and Evers like to use to define these twitches. And so we're going to use them as well. If a drug is very potent, that drug's dose is going to be fairly small to give me 95% twitch depression. So it's going to take less of a dose to see my twitch response fall. That's potency according to Stolten and Evers. Onset is going to be from the time that you give the drug until your loss of twitch. The duration of action will be your time to return of twitch height from 25% height to 95% height. And then the duration will be determined by your frame of 4. That's great, sir. What do you mean? Goes back to this curve again. If you know when you gave the drug and you know where your twitches went away, you know your onset. Time to 95% recovery is exactly that. How long until my twitch height is 95% of what it was without the drug on board? But remembering that other slide that we had, just because you have return of twitch height, does that mean all of your receptors are free? A huge proportion could still be blocked, 75% or greater. And that's what this slide is saying here. It just gives you some lines to correlate certain functions, right? So here we start to have the return of twitch height. That's still a little bit less than 95% blockade. This is where we have time to 95% recovery, and we're still not at full twitch height. And then finally, even with 75% of receptors blocked, we have a full twitch height. So that's awesome, but what does train of 4 mean? Train of 4 is a relative measure of each twitch's magnitude. It is a series of 4 twitches that you can either palpate manually or put on some type of measurement device and measure the amplitude of the response. You're going to be dealing with train of 4 ratios. The train of 4 ratio is simply the magnitude of the 4th twitch that you apply divided by the magnitude of the first twitch that you apply. Now let's see if you can track this. Why will succinylcholine's train of 4 always be 1 in a phase 1 block? They may be diminished, but they're the same height. So the 4th twitch's height is equal to the first twitch's height. So why could you have a train of 4 ratio of 0.25 with a non-depolarizing neuromuscular block? The 4th twitch is 25% the magnitude of the first twitch, right? 25 divided by 100. If you're saying the first twitch is 100% and the last twitch is 25% in height, you compare them, that's where you get that ratio. Everybody tracking that. That's your train of 4 ratio. That is what you're going to use clinically to monitor this neuromuscular blockade. Have I got to 60 yet? We'll stop there. We're gonna cook tomorrow though, so be prepared. You guys, I'll give you 20 minutes for your test. Just try to read a little bit of this tomorrow, and we'll get cooking on it again. Thank you.
Good question, please, on the test tomorrow.